We spoke about the hyper-utilization of operation theaters as one of the unique phenomenon that characterizes Aravind eye care system. As you look at this slide here, Aravind has operation theaters that have two or more tables with multiple equipment and instrumentation. So, a surgeon performs a procedure on one table and then swings the microscope to the other table to perform the next surgery. And as this happens, the nursing unit prepares the earlier and or the next table with the next patient. Now, this way, an average surgeon at Aravind performs over 2,000 eye surgeries in a year. That is, as you see, on an average, 6 to 8 surgeries per hour. Because instead of one, you have 6 instrumentation sets. Instead of one scrub nurse, you have 2 scrub nurses in the theater. And instead of one, you have 2 tables. And of course, there's just this one surgeon who is doing this. Now, it is debatable whether this technique or method can be equally applied to other procedures. But the point is that this must be considered and evaluated, because this is one solid way in which hospitals can potentially beat fixed costs. And not just that, you also look at the safety metrics, because the question can come, if you're doing these kinds of volumes and you have this kind of hyperutilization of OT, what about the safety metrics? Now, this is a slide which talks briefly about Aravind's safety metrics or quality indicators, where the complication rates have been compared to some of the best hospitals in the NHS system in the UK. Now, as is evident from this slide, the complications rates of Aravind for capsule rupture and vitreous loss is less than 1/2 of what you will find at the NHS in UK. Cortical cleanup is about 3/4 of the complication rates that you find within the NHS in the UK. Iris trauma, less than half. Persistent iris prolapse, almost 10% of the complication rates in the UK, and so on and so forth. I mean, choroidal hemorrhage is almost non-existent, as is loss of intraocular lens into the vitreous. So not only is Aravind able to perform numbers at mind-boggling volumes, but the complication rates are less than half of what you will find in some of the most reputed hospital networks within the NHS in the UK. And therefore, they're also able to drive down procedure economics. So for this mind-boggling volume and for the number of ophthalmologists that graduate annually, the first 2 graphics on this slide, which compare Aravind, which is the shaded portion, and the NHS, you can see that the average annual cost of delivering eye care is close to 1.6 billion with a B pounds sterling when it comes to the UK NHS, and Arvind's able to deliver as much, if not more, at 13.8 million. That is an absolute fraction of what you will find in the NHS. Therefore, you're able to marry high volumes with equally high quality. And in conclusion, I just want to quote Aravind Srinivasan. He says, "We let our doctors focus on what they are best at, diagnosis and surgery. Nurses and technicians perform tasks in the operating room that don't need a doctor's skills. We intend to perform over 1 million surgeries every year. Affordable and high quality will always be in demand," says Aravind Srinivasan from the Aravind Eye Care Network. Now, you see these days doctors sometimes becoming glorified clerks, right? The thing which comes to my mind is the EMR. The EMR system has forced doctors to become clerks. And not all of them are quick at typing, and they take a lot of time that probably is better spent on diagnosis, better spent on designing care pathways, and definitely better spent on performing procedures. But when you visit a hospital these days, you barely are able to make eye contact with the doctor because the doctor is typing a discharge summary or the doctor is typing whatever you're saying and is not even listening to you. So these are hospitals that have taken a high cost doctor and having spent a lot of their time doing things which has nothing to do with diagnosis, designing care plans, or treatment pathways. Doctors must remain focused on diagnosis and on designing the care delivery or performing procedures. Today, many hospitals have burdened doctors with tasks that can be done by other resources. Because not only is this irrational, but it also rushes doctors, which could have many other unintended and negative consequences. So, just reiterating what Aravind Srinivasan says on this slide, I also spoke to a senior physician at Aravind, and he said that, and he basically underscored that basic philosophy. The doctors remain focused on diagnosis and treatment plans. Nurses and technicians are elevated to do tasks that we might see doctors doing in other health systems. Good. With that, we'll now move into the next topic of the hospital capital structure. But before that, I'll leave you with a brief introduction and an overview of the idea of OL, or operating leverage, which measures the fixed cost and the dilemma that fixed costs provide in terms of driving risk into the business of hospitals.